Okay, so here I'm going to talk about a very important pathogen of the lower respiratory tract, and that is Mycobacterium tuberculosis. And so tuberculosis has a very heavy worldwide burden. There are about almost 2 billion people infected. Overall, it's thought that about 3 million people die each year, and there are important comorbidities with tuberculosis. AIDS as well as HIV infection are having a significant role in this comorbidity with tuberculosis worldwide. There's also an increase of drug resistance, and that is primarily due to noncompliance. So people have to be on drugs for a very long period of time, and they stop taking their drugs. And so emerging tuberculosis, drug-resistant tuberculosis is very important to counter. For tuberculosis, detection of this actual infection is very vital. Symptoms are going to be very similar to other respiratory symptoms. You're going to have flu-like symptoms, fever, fatigue, shortness of breath. This can also go along with weight loss and coughing as well. Now, Mycobacterium tuberculosis is a bacillus-shaped bacterium. It is going to have a mycolic acid that's going to be on its surface, and this is going to allow it to evade our immune defenses. It makes it sort of slippery. It's hard for your immune system to fight. And because it has mycolic acid, it also has a different staining pattern than other bacterium. You have to use what's called an acid-fast staining pattern rather than the typical gram staining. And so acid-fast staining is basically you stain the bacterium, you add an acid. If it maintains that stain, then that's called acid-fast because it's able to maintain the bacteria in the presence or maintain the color in the presence of the acid. Your mycolic acid is going to be protecting from antibiotics as well. The antibiotics can't get through that waxy layer in order to attack the peptidoglycan layer, for example. It's also going to help it to protect from T cells, our phagolysosomal fusion. So remember, our macrophages will eat bacteria. So your macrophages are very important in the pathology of your TB. Macrophages eat bacteria. And typically you'll have a lysosome. And this is a compartment in your macrophage, and typically they will merge. And then the lysosome enzymes can digest the bacteria. But this does not occur in Mycobacterium tuberculosis due to mycolic acid. It does not allow that merger. And so basically your bacteria survive. And they're in the endosome compartment. And so they're inside the macrophage, but they're not inside the cytoplasm of the macrophage. They're kind of inside of their own little compartment, their own little area to replicate, and they replicate to very high numbers. Now, your Mycobacterium tuberculosis is typically going to be controlled by the immune system. It does not get cleared by the immune system. However, if there is some compromise with the immune system, the Mycobacterium can get into the cytoplasm. It can increase in numbers. It can spread to other areas of the body and cause a miliary or disseminated Mycobacterium tuberculosis. So there are basically two types. We have primary and then we have secondary TB. And our primary TB is when you first get exposed to the actual bacterium, the primary infection. And this is going to cause what we refer to as a Ghon's complex. This is basically where you get a granuloma that forms, and within the middle of the granuloma you have a caseous necrosis that forms. After the primary, three different things can happen. If you have an immune compromised individual, you can get dissemination and what's called a medullary TB. Most people, about 90% of people, have what's called a silent infection. And this basically is that they have a localized infection or granuloma that forms at the site of infection, and then this gets under control and the people don't present with any other symptoms. And then 10% will have reactivation to secondary TB. And so secondary TB is going to be caused by some sort of trigger. And so that can be an exogenous infection. So some other infection triggers a superinfection with a bacterium, for example. Or it can be an endogenous reason. Perhaps you have someone who's been compromised, they are undergoing cancer therapy or something, they're HIV infected, something triggers this secondary TB to grow out again. And then in the secondary TB, you have caseous necrosis that occurs in caverns within the lungs. It can lead to open TB, which you get spread to the bronchial system and also becoming contagious. Or you can have extrapulmonary TB, and this is where you get spread through the blood system to other areas of the body, including the central nervous system. So primary TB, you're going to, again, have this Gones complex, which is shown here. You're going to have your phagocytosis of the bacilli. However, they cannot kill those bacteria, as I mentioned before. The bacteria are going to be taken to draining lymph nodes, continue to divide. You're going to get a primary lesion that gets contained, or you're not going to contain it and have tuberculose form. Now, your tuberculose are going to be basically aggregates of those macrophages that are trying to eat the bacteria and kill the bacteria. And then they're going to surround themselves with fibroblast cells that are trying to, again, contain this infection. They're trying to repair the damage. The center is going to undergo caseous necrosis, and this can lead to calcification, forming Gones complexes, and you can see these dots on your x-ray. Now again, only about 10% will evolve into a clinical case. You can have a tuberculosis meningitis or a miliary disseminated tuberculosis. Secondary TB, again, reactivation of your old lesions, and this will occur in some patients due to some triggering event, and it's usually going to occur within 2 years of the primary infection. However, it can occur later simply because we don't eliminate the bacterium from our bodies. Instead, we just contain it. So when you have a diminished immune system at some stage later in life, that can lead to triggering of your tuberculosis. So tuberculosis treatment is very important, especially with all the arising antibiotic-resistant tuberculosis. Typically, you're going to use the same strategy that's used for HIV, where you're going to pile on multiple different therapies at the same time, so that if one tuberculosis bacterium is resistant to one of the treatments, it usually cannot be resistant to the other two as well, so the other two will take care of it. And so this is just an example of the triple therapies that can be taken. And if you look at this, we have a long time period for these. We have 9 months, 2 months, etc. And so there's a lot of compliance issues associated with tuberculosis treatment. So compliance is difficult, and it's due to the side effects. So most of these therapies are going to lead to liver toxicity. Now, one thing that has been developed is a way to manage these patients and to help them to remain compliant. So there's direct observed therapy, or DOT, and this is important in trying to keep people who are infected with TB so they don't develop into multi-drug resistant tuberculosis. And so usually a healthcare worker will work with these tuberculosis patients to administer, observe, document, and make sure they're staying on their treatment schedules.